It is now my pleasure to introduce today's program. This program will provide a comprehensive overview of Helicobacter pylori diagnosis, the clinical impact to patients due to gaps in care, and the benefits of utilizing an active infection test for H. pylori detection. I would now like to introduce today's speaker, Dr. Amir Ali, Associate Professor of Medicine and Gastroenterology at George Washington University in Washington, D.C. At this time, it is my pleasure to turn the program over to our presenter, Dr. Ali.
Thank you, Sarah, and thank you to all the attendees for joining us in this discussion of current trends in H. pylori testing and treatment. This is my financial disclosure. Over the course of the next 45 minutes, we will go over the disease states that are associated with H. pylori infection. I will go over the economic impact of some of the major disease states that are found due to H. pylori infection. We will discuss the pathogenesis of H. pylori and the disease progression from infection to gastric cancer. H. pylori will also be discussed in the context of bariatric surgery, which is being performed more and more often as we recognize its benefits to the high BMI population. I will also go over the society guidelines, the Gastroenterology Society guidelines pertaining to H. pylori diagnosis and treatment. I will discuss PPI use and the risks associated with long-term use of these medications. The different modalities for diagnosing H. pylori will be discussed along with their relative merits and weaknesses. The treatment of H. pylori will also be discussed, as will antibiotic resistance, which is a big impediment to effective treatment of H. pylori. So let's start out with a discussion of the various disease states that are associated with H. pylori. One of the things that makes H. pylori such a relevant pathogen to be aware of is its overall prevalence. About 30% of the American population is infected with H. pylori. Within the U.S. and globally, H. pylori is the most common chronic infection, and it results in a variety of disease states. It's a bacteria that infects the lining of the stomach, and one of the main disease states that it's responsible for, and the one that was recognized earliest, was peptic ulcer disease. The majority of cases of peptic ulcer disease are caused by H. pylori. H. pylori is also a common cause of dyspepsia. Infection with H. pylori occurs at an early age. Most patients who have the infection contracted it before the age of 5. And the mode of infection is fecal-oral contamination. And consistent with this mode of transmission, the areas where the infection is most prevalent are the areas where levels of sanitation are lower. And hence we see higher levels of infection, higher rates of infection in developing countries. Now, dyspepsia, which is one of the things that is caused by H. pylori, is one of the top 5 reasons why patients go to see their primary care providers. So it's relevant to all of our practices. H. pylori is a known risk factor for gastric cancer. The World Health Organization has classified it as a carcinogen. There was an article in the journal Lancet about 4 years ago which listed H. pylori as one of 6 common infections that lead to cancer, and hence it classified H. pylori as a modifiable risk factor for cancer. Aside from gastric adenocarcinoma, H. pylori is also associated with malt lymphoma. Low-grade malt lymphomas can be cured by eradication of H. pylori. And finally, bariatric surgery is being done more and more often these days. One of the common reasons why patients with bariatric surgery or patients who have undergone bariatric surgery get rehospitalized is because of marginal ulcers. Now, H. pylori has a role in the genesis of marginal ulcers also. In terms of economic impact, given the sheer high prevalence of H. pylori and given the diversity of disease states that it causes, it is not surprising that it has a tremendous economic impact. Peptic ulcer disease affects more than 6 million Americans every year. In fact, about 1 in 10 Americans at some point in their life will suffer from peptic ulcer disease. The annual cost of this disease is about $6 billion. Half of this expenditure is in hospital costs. Of the remainder, $2 billion are spent annually on physician office visits, and about $1 billion are lost due to lost productivity from work. And related to peptic ulcer disease is the relationship of H. pylori with marginal ulcers. Given the higher rates of bariatric surgery that are being performed, higher numbers of bariatric surgery that are being done, untreated H. pylori is becoming a significant issue because it has a role in marginal ulcers, which are one of the most common reasons why patients get readmitted after bariatric surgery. This is a representation of the disease progression associated with H. pylori. H. pylori infection typically results in some vague symptoms, abdominal discomfort, maybe some nausea, and once the acute infection takes hold, within the subsequent weeks and months, chronic superficial gastritis can be found endoscopically on these patients. Now, once H. pylori infection has been established and chronic superficial gastritis occurs, this can progress to peptic ulcer disease, or it can remain as chronic superficial gastritis for a number of years, perhaps even for the lifetime of the patient. Chronic superficial gastritis can progress to lymphoproliferative disease or chronic atrophic gastritis. Chronic atrophic gastritis is the point at which progression to adenocarcinoma can occur. So patients with chronic atrophic gastritis can either remain as chronic atrophic gastritis or progress along the continuum and develop gastric adenocarcinoma. About 1% of patients who become infected with H. pylori will develop gastric adenocarcinoma over the course of their lives. Now, the economic impact of gastric cancer is very significant. It's a devastating disease. Over 20,000 new cases are diagnosed every year, and about half of that number result in death. The 5-year survival for gastric cancer is abysmal. It's only about a quarter of patients who are diagnosed with this disease are alive 5 years after their diagnosis. The expenditure is about $66,700 per diagnosis, which annually accumulates in about $1.5 billion. And again, these are healthcare expenditures, and they're really overshadowed by the degree of human suffering that this disease causes. Now, dyspepsia is very common. It affects about a quarter of the American population, and it results in about $2 billion in expenditure. More than 1 million hospitalizations are the result of dyspeptic symptoms due to H. pylori. A significant driver of the high costs associated with dyspepsia is the overuse of endoscopy. Now, there is an appropriate use of endoscopy and there is an inappropriate use of endoscopy. In patients who are low risk for complications, endoscopy should not be the first step, and the guidelines that we will go over emphasize this. What we find is that 63% of these low-risk patients who have dyspepsia end up having endoscopy as a first test before undergoing the recommended non-invasive testing for H. pylori. Now, we'll go over H. pylori and bariatric surgery. The American Society of Gastrointestinal Endoscopy issued an initial set of guidelines in 2008 regarding H. pylori testing and preoperative evaluation before patients undergo bariatric surgery. And they recommended that H. pylori testing should be done routinely before patients undergo bariatric surgery. This recommendation was made because of the role of H. pylori in the development of marginal ulcers. What is also important to note in the bariatric surgery population is that H. pylori eradication is more difficult in this group of patients. While typical eradication rates in the non-bariatric population are about 85% after treatment for H. pylori, these rates in obese patients are much lower, about 55%. Much of this is thought to owe itself to bioavailability of the medications, but it's certainly a significant difference compared to the general population. And the reason it's important to note this is because when we treat our high BMI population for H. pylori, it is doubly important to retest this population to make sure that successful eradication has in fact been accomplished, because a very high proportion of this population, even in spite of taking the medication and being adherent with the prescribed dosages, still fail to eradicate the bacteria. H. pylori is a common cause of marginal ulcers. The likelihood of marginal ulcers after bariatric surgery has sort of shifted over the years. It can range anywhere between 1% to 16% of cases in which marginal ulcers develop. Patients who have had H. pylori eradicated before bariatric surgery have a lower likelihood of developing not just marginal ulcers, but also perforations of hollow organs. Hospital readmission after surgery is a measure that is subject to the CMS star rating, and hence it's part of all of our performance evaluations. So it's important to think of H. pylori testing before we send patients for bariatric surgery. It's also important to note that once patients have bariatric surgery, portions of their stomach are excluded from examination by endoscopy. And patients who have ongoing H. pylori infection can develop peptic ulcer disease or gastric adenocarcinoma in these excluded portions. And it's significant to note this because were peptic ulcers or adenocarcinoma to develop in the excluded portion, it is far more difficult to diagnose it, and it will be diagnosed at a much later stage. And it can all be prevented by checking for H. pylori before sending these patients for surgery. The financial cost of H. pylori infection and its related complication in bariatric surgery is predictably high. It's about $27,000 per 100 cases. The next slide is a diagram of the American Gastroenterological Association and the American College of Gastroenterology guidelines as they pertain to H. pylori testing in dyspepsia. Now, the takeaway point from this slide is that when a patient comes to us with dyspeptic symptoms, the main decision point is to determine whether the patient needs to have an upper endoscopy or whether the patient should first have non-invasive testing for H. pylori infection. And this decision is made on the basis of age and alarm signs. If a patient is older than age 55, or if the patient has any alarm signs are any sign of GI bleeding, anemia, weight loss, lymphadenopathy, family history of cancer. If any of these alarm signs are present, or if the patient is older than age 55, they should have an upper endoscopy. And the reason is that this subgroup of dyspeptic patients is the subgroup in whom complicated disease, meaning disease that or symptoms that are caused by either cancer or by complicated ulcers, ulcers that are causing obstruction or bleeding. It basically tells us that this is the group of population that is at a higher risk for developing those complications, and hence this is the subgroup that should be managed aggressively with early endoscopy. Now, the remainder of the population, individuals who are younger than age 55 and who do not have any alarm signs, this group of patients are at a pretty low risk for having underlying malignancy or of having underlying complicated ulcer disease. So this is the subpopulation in whom endoscopy should not be the first test. This is the low-risk subgroup who should first be tested with a non-invasive test of active infection of H. pylori. Now, what are the non-invasive tests of active infection? The H. pylori stool antigen or the urea breath test. So the take-home message in this slide, and the take-home message from the ACG and the ACG Guidelines, is that when a dyspeptic patient comes and sees us, what we first should do is stratify their risk of having complicated disease. And this stratification is done by looking at the patient's age and looking at the presence or absence of alarm signs. If the patient is older than age 55, and if the patient has any alarm signs, early endoscopy should be pursued. For the remaining patients who are younger than age 55 and who do not have alarm signs, we should perform a non-invasive test of active infection. And if that test shows the presence of H. pylori, we should treat the patient, and we should retest the patient to confirm eradication, because eradication rates over time have fallen due to antibiotic resistance. And even though we have prescribed the medication and the patient has taken it, there's a significant likelihood that eradication has not been achieved, and we need to identify those patients in whom eradication has not successfully been achieved and to target them for retreatment. So in summary of the guidelines, the main decision point is early endoscopy or non-invasive testing, and that is aided by looking at the patient age and the presence of alarm signs. In terms of non-invasive testing, we perform that in patients who are younger than age 55 and who do not have alarm signs. We test them for H. pylori. If H. pylori is present, we treat for the infection, and we retest to confirm eradication. And this is largely due to significant eradication failure resulting from antibiotic resistance. Clarithromycin resistance, for instance, occurs in about 25% of the strains of H. pylori that infect our patients. Now, why were these guidelines promulgated? There are several reasons. The first is the overuse of proton pump inhibitors. A lot of times when patients present with dyspepsia, they are placed empirically on a proton pump inhibitor. And this is generally done without looking for an underlying reversible cause of the patient's symptoms. Once PPIs are started, very often they're represcribed and the patient ends up being on them chronically, because when they stop the medication, their symptoms come back because the underlying cause has not yet been addressed. The use of PPIs in this manner is significant because of the cost it incurs, no doubt, but also because of the significant side effects that are associated with proton pump inhibitors. We are learning more and more that these medications are not the benign medications that we once thought that they were. New research is coming out, it seems every month, which points to additional risks associated with chronic PPI therapy. So if we can identify the patients who are on PPI therapy, or before placing patients on PPI, and identify those patients who have H. pylori, and if we can eradicate H. pylori, we have the potential of getting rid of the patient's symptoms and not having to place these patients on PPIs as they are no longer having symptoms. The other reason for the guidelines was the overuse of endoscopy in the low-risk population. Again, the low-risk population is dyspeptic patients under age 55 who do not have alarm signs. These low-risk patients, once their H. pylori is treated, can experience improvement in their symptoms and may not need the invasive and the expensive interventions that endoscopic evaluations are. And next, the overuse of serology also prompted these guidelines. Now, serology is an easy test to do. It's a blood test, but it is beset with several limitations. The main limitation of serology is that it's not a test of active infection. Serology merely tells us that the patient having the test was exposed to H. pylori at some point in the past. It does not tell us whether that infection is still present. This is significant because if we look at positive serologic tests in the United States, the positive predictive value, meaning the true positives, are only about 50%, which means that if we look at serologic tests, 50% of positive tests are falsely positive. So if we were to rely on serology to prescribe treatment, about half the patients that we would be treating for H. pylori would not need the treatment. And it is this significant limitation of serology that has led to the guidelines recommending against using serology. And lastly, the other side of the coin is the test of active infection. Serology is not a test of active infection, and hence it's a limited test. So the preferred test would be a test that evaluates for ongoing active infection. And these tests tell us whether or not the patient has infection at the time that the patient is being tested, and it allows us to offer therapy only to those patients who need it. Active infection tests are the H. pylori stool antigen test and the urea breath test. Now, let's talk a little bit about proton pump inhibitors. As I mentioned briefly, we are learning some of the long-term side effects associated with proton pump inhibitors. We have always known that they are expensive drugs and they result in a significant annual expenditure in the United States. We spend over $11 billion as a country on proton pump inhibitors. These medications are one of the top 5 medications in terms of pharmacological spending. Now, what is interesting is that if you look at all the patients who are taking PPIs, who are receiving multiple prescriptions of PPIs, and if you evaluate the indication, it appears that only about a third of these patients on chronic PPIs have an appropriate indication for these medications. What is also important to note is that when we look at patients who are taking PPIs chronically, if we were to test them for H. pylori, about 28% of these patients are H. pylori positive. So what this tells us is that 28% of these patients who are on chronic PPIs had perhaps a reversible cause of their symptomatology, which if it were diagnosed and if it were treated, these patients would no longer have required the PPI. So it's important to recognize that before starting a patient on a PPI, we have an opportunity to test them for H. pylori and to diagnose a potentially treatable and reversible cause of their underlying symptoms. So based on these studies, given that a significant proportion of PPI prescription is occurring in a population that does not have a good indication for the medication, about $7 billion of the expenditure is for inappropriate indications. Now, a lot of you are probably answering emails and phone calls, as I have been in the recent weeks, regarding the recent articles that outlined an association between PPI use and coronary artery disease, between PPI use and chronic kidney disease, and between PPI use and dementia. These were articles that were in the news quite a bit, and they highlight the fact that any drug that we use chronically in large populations can result in significant side effects. Now, while these studies are preliminary, we have some established risks associated with proton pump inhibitor use. The most well-established of these risks is the risk of fractures. Patients who are on chronic PPIs, typically if they've been taking the PPIs for more than 5 years, are at significantly increased risk of fractures. And there seems to be a dose dependence and a duration dependence in the increase in the risk of fractures. And this has been replicated in more than one study, and this long-term complication of PPI use is well established. In fact, when we see patients who are on long-term PPIs, we should document in our notes that we discussed with them the risks associated with PPI use, including fractures, infections, drug interactions, and decreased vitamin and mineral levels. Now, the other long-term risk of chronic PPI use is C. difficile and other intestinal infections. Patients who are on a PPI are at significantly higher risk of developing C. difficile infection. They're also at higher risk of having recurrent infection. In addition to the fractures and the C. diff infection, there are several drug interactions associated with PPI use. The most significant is perhaps the interaction with the antiplatelet agent clopidogrel. Clopidogrel, as you know, is an antiplatelet agent that's used frequently in patients who have had coronary artery disease and typically have had a stent placed in their coronary vessels. It has been found that the antiplatelet effect of clopidogrel is decreased when it's co-administered with a PPI. And this has significant implications because if the antiplatelet effect of clopidogrel is diminished, these patients can develop thrombosis of their stents, and that, as you know, is a very serious complication. The FDA has required warning regarding the co-administration of clopidogrel and proton pump inhibitors as a result of this interaction. Patients who are on long-term PPIs also have decreased vitamin B12 and magnesium levels. The low magnesium levels are significant because they can result in arrhythmias. They can reduce the arrhythmogenic thresholds, and hence patients who are on long-term PPI should periodically be tested for their magnesium levels. There's also a phenomenon of dependency. Patients who start taking a proton pump inhibitor become used to being on the medication, and when the medication is withdrawn, they develop rebound hypersecretion of acid and symptoms that are worse than the symptoms they had when they started the medication. There was a study in 2009 in which healthy patients, I should not call them patients, they were healthy volunteers, were started on proton pump inhibitors. And they continued taking proton pump inhibitors for 8 weeks. Remember, these are patients who had no symptoms. They were healthy volunteers. At the end of 8 weeks, the proton pump inhibitor was stopped abruptly. When the PPI was stopped, a significant proportion of these healthy volunteers developed acid-related symptoms when they had never had them. So this highlights the importance of rebound acid hypersecretion. When people are on a PPI long-term and they stop the medication, they end up experiencing rebound acid hypersecretion for a period of about 2 weeks. And when they are in this phase where they're making a lot of acid because they just stopped the medication, they call their physician, they complain of symptoms, they call and they tell us, well, I didn't realize my symptoms were this bad. They're very severe after stopping the medication. Please place me back on the medication. And very often we put them back on the medications, and what may have started off as what may have been intended as a short-term use of PPIs ends up becoming chronic use of these medications. And it's no surprise then that patients who start treatment with PPIs, about a third of these patients end up continuing to refill their prescription multiple times in the absence of a good indications for maintenance. Now, let's discuss endoscopy. Endoscopy is performed routinely, but we should keep in mind that it is an invasive procedure. It is done after administration of either deep sedation or general anesthesia. It is considered the definitive test for H. pylori diagnosis, and the diagnosis is made on biopsy. So for patients who are older than age 55 and for those patients who have alarm signs, they are undergoing endoscopy to look for complicated ulcer disease or gastric cancer. So in these patients, gastric biopsy is often obtained, and H. pylori diagnosis is made on histologic analysis of the biopsy specimen. So in this high-risk group of patients, an endoscopy is already being performed, and obtaining a specimen is routine as part of the endoscopy. But it's important to note that in low-risk patients, this is an invasive test with facility costs, physician costs, anesthesia costs, histology costs, etc. and on average, an upper endoscopy ends up costing the healthcare system about $2,200. So in the low-risk patient who the guidelines suggest should be evaluated with non-invasive tests of H. pylori infection, endoscopy is an invasive and expensive way to do something that far less invasive and far less expensive tests can just as easily and just as well accomplish. Now, as I mentioned before, biopsies are obtained during upper endoscopy, and these specimens are examined under the microscope. Rarely culture is performed on these specimens. In the past, flow tests or rapid urease tests were performed on histologic specimens or on biopsy specimens. This is not being done routinely anymore. The main method by which endoscopic diagnosis is made is by histological staining. Serology is the first non-invasive test of H. pylori that was developed. It has severe limitations. Serology merely tells us whether the patient was exposed to H. pylori in the past. It is beset with several problems, the most significant of which is that serologic tests are limited by serological scars, meaning once a patient becomes positive serologically for an infection, that patient tends to remain positive for years, if not decades, after the infection has been successfully eradicated. And this is true of H. pylori as well. Patients become infected, they're treated with antibiotics either to treat H. pylori or to treat other conditions, but these antibiotics may have the effect of eradicating H. pylori in these patients. But the patients will remain positive on serologic testing, and if we were to rely on serologic testing, we would end up treating these patients unnecessarily for H. pylori. The positive predictive value of a serologic test is only about 50%. So with the background prevalence being what it is in the United States, the positive predictive value of serology is only about half. So half the positive tests are falsely positive. The other significant limitation of serology is that it cannot be used to confirm eradication, because once someone becomes positive, they tend to remain positive. So even if you get rid of the infection, if you repeat the test will still be positive. So in this scenario, there is no role for the use of serology. There was a study which was published last year which looked at the 3 different non-invasive tests for H. pylori infection. And what it found was that serologic testing is the most commonly used test of H. pylori infection. It is performed 6 times more often than the H. pylori stool antigen test, 4.5 times more often than the urea breath test. So the test whose use is discouraged by the society guidelines is in fact the most commonly used test, and this needs to be brought more in line with what the recommendations are. What this tells us is that if the majority of patients are being tested for H. pylori with the serologic test, a lot of patients are being treated for H. pylori based on false positives. So about a significant proportion of the population who is being treated for H. pylori has been diagnosed with H. pylori based on serology, which is limited. So about half of these patients who are being treated unnecessarily. And the conclusions of this article was that there is a substandard adherence to guidelines in terms of the utilization of H. pylori non-invasive tests. And the discussion went on to say that a more drastic incentive-based measure to limit the use of serology may be necessary to bring practice in line with the recommendations. And recent trends are concordant with these recommendations. Many reference labs have discontinued offering serologic testing to align themselves with the ACG and the AGA guidelines that highlight the limitations of serologic testing. There are many health plans that have also issued medical policies regarding H. pylori because it's a common disease state. And in these medical policies, they have emphasized that appropriate testing for H. pylori should be not with serology, but with the test of active infection. Many providers have, or health insurance providers have gone a step further and have made the decision to no longer reimburse for H. pylori serologic testing. Cigna, Aetna, Horizon, Blue Cross Blue Shield, Emblem, all of these have taken that extra step. So this really highlights the recognition that our current practice is not in line with guidelines, the fact that the test that has severe underlying limitations ends up being utilized, and healthcare decisions are being made based on a test that is admittedly a limited test with a high level of inaccuracy. Now, looking at all three non-invasive tests, the sensitivity and specificity for the H. pylori stool antigen test is high, exceeding 95%. The urea breath test also has a high sensitivity and a good specificity. Serology has lower sensitivity and specificity, but as we mentioned, the very telling weakness of serology is its low positive predictive value and its high rate of false positive results. Now, after treatment has been offered for H. pylori, the stool antigen test remains highly sensitive, as does the urea breath test. Serologic testing has no role in this situation. Serology testing should not be performed to confirm eradication. Now, the urea breath test is one of the tests of active infection that is supported by the AGA and the ACG. It's cleared for use in both the pediatric as well as the adult population. It is non-invasive, but it is beset with several disadvantages. The urea breath test requires special setup on part of the facility that's doing the test. A reagent has to be prepared. The patient fasts, takes the reagent, and breath samples are taken at various time intervals. So it's a several-step process. And as we all know, the more steps there are to a process, the greater the likelihood that one of those steps does not happen as per prescription, and we can end up with inaccurate results that way. The patients have to stop their proton pump inhibitors, even their bismuth, for 2 weeks prior to testing. Some patients have had adverse reactions related to the reagent that's used for urea breath testing. So all of these are limitations of the urea breath test. Now, the H. pylori stool antigen test is the other test of active infection. Many insurance plans have selected this test as their preferred test because it's cost effective, it's accurate, it's easy to perform. It has several significant advantages. One is the high sensitivity and specificity. It's cleared for use in patients of all ages. It's simple to administer. There's no special setup, no calibrations, no fasting or dietary restrictions on part of the patient. They just have to provide a sample, which is quite easy to provide. It is very highly sensitive and specific, both for the initial diagnosis of H. pylori and for post-treatment confirmation of eradication. When it is clinically necessary or desirable, the test can be administered in the setting of ongoing PPI and H2 blocker use. It is not affected, in fact, by bismuth and H2 blockers. Because of all of these features, because of the ease of administration, cost efficiency, or cost effectiveness, and high sensitivity and specificity, many payers select it as the test of choice. United Healthcare, which is the biggest private insurance provider, has designated the H. pylori stool antigen test as their preferred test very recently. Now, the next slide looks at the time frame. When patients are diagnosed with H. pylori, in the United States, they typically receive 14 days of antibiotic therapy. So after these 14 days of antibiotic therapy are completed, the patient should not be tested for 4 weeks, because in this period of 4 weeks following eradication of H. pylori, the test results can be inaccurate. So we should test for H. pylori after 4 weeks of completing eradication therapy. And at the end of 4 weeks, we should check for H. pylori to make sure that successful eradication has been achieved. The treatment regimens that are used most commonly, the first-line regimen is amoxicillin, clarithromycin, and a proton pump inhibitor, all taken twice a day for 14 days. For those who are penicillin allergic, the alternate regimen is metronidazole, tetracycline, bismuth, and a PPI for anywhere between 10 to 14 days. Now, if these regimens do not work, quinolone-based regimens are considered to be second line, and they're employed if H. pylori tests are positive after eradication. The MASTED guidelines, which are comprehensive guidelines about the diagnosis and treatment of H. pylori, have mentioned the fact and have taken note of the fact that H. pylori infection with current therapies allows a cure rate of only about 70%. And this means that about a third of patients, 30% of patients, even after treatment, are not free of their infection. And these patients need to be identified and targeted for retreatment. Now, what are the consequences of failed H. pylori eradication? One is that additional doses of antibiotics are necessary. And when we use more and more antibiotics, we start seeing antibiotic-related adverse events, whether it's drug reactions, C. difficile infection, etc. In addition, when a patient is prescribed a round of triple therapy and they fail the treatment, this often results in specialty referrals, either to gastroenterology or infectious disease, and this results in additional workup and cost. Oftentimes when eradication fails, the patients continue to have their symptoms, and hence they keep receiving therapy for those symptoms with proton pump inhibitors, so it can prolong their course of PPIs and subject them to the long-term risks of those medications. And in addition, when their symptoms continue after failing therapy for H. pylori, they're subjected to endoscopic evaluation when successful eradication may have removed the necessity for this evaluation. Now, what are the causes for H. pylori treatment failure? The first and foremost is antibiotic resistance. We use antibiotics often and sometimes for marginal indications, and as a result, many resistant strains have developed. Virulence factors and genotypes of the H. pylori strain can also determine their susceptibility to antibiotics. The site of infection can affect sensitivity to antibiotics, and sometimes H. pylori can assume a coxoid form, which is less responsive to antibiotics. Host factors, genetic polymorphisms result in varying responses to antibiotics. Non-compliance, many of these medications have GI side effects, so patients who many times may not be having any symptoms or mild symptoms, when they're prescribed a course of antibiotics for H. pylori, may find that the medications cause more severe symptoms than the actual disease, and they may stop taking the medication or not take it as recommended. Smoking has also been shown to reduce sensitivity to H. pylori eradication. Now, resistance to H. pylori is largely caused by clarithromycin resistance, because clarithromycin-based regimens are the most commonly prescribed regimens, and there's about a 29.3% resistance to clarithromycin in the H. pylori strains that we encounter in the United States. There's a 44% resistance to metronidazole, but remember, this is not the first-line therapy, it's an alternate therapy, so it's not prescribed as often. So it's not responsible for as high of a proportion of treatment failures. Now, 80 to 90% of clarithromycin resistance is due to mutations in one gene, and hence genotypic analysis can easily help diagnose resistant strains. It has been found that genotypic analysis correlates with phenotypic expression in 85% of bacterial isolates. And not surprisingly then, if we use susceptibility-guided treatment as opposed to empiric treatment, if we use a tailored antibiotic approach based on susceptibility testing, the eradication rate bumps up to 95%. Whereas if we just treat empirically without testing for susceptibility, the eradication rate is only about 72%. So we have a significant gain in antibiotic response if we use susceptibility-guided treatment. So clarithromycin susceptibility testing allows us to close the gap in care because it helps us individualize the antibiotic regimen. It improves the eradication rates from 72% to 95%, which is quite a significant improvement. It promotes antibiotic stewardship because we put these patients on the correct antibiotic at the first go, rather than arriving at the correct regimen after having a trial and error with several other regimens. Now, PCR testing can be performed on the same specimen which was submitted for H. pylori detection, so that makes it easy to get susceptibility testing. It does not require an additional specimen. If we can increase our rate of H. pylori eradication, we can reduce PPI overuse, and we can reduce the overuse of endoscopy. So in summary, H. pylori is associated with a variety of disease states, significantly peptic ulcer disease, gastric cancer, marginal ulcers, dyspepsia. It has a significant economic impact. The AG and the ACG guidelines are emphatic in saying that patients younger than age 55 who do not have alarm signs should be tested with non-invasive tests of active infection. And serology is not a test of active infection, and hence its use in non-invasive diagnosis of H. pylori is not supported by the guidelines. H. pylori treatment is successful only 70% of the time, and this is because of antibiotic resistance. So this tells us two things. One, that we should retest to confirm eradication, and two, susceptibility-guided therapy or susceptibility testing, if it is available, has a significant benefit. And now I'll take any questions that any of you may have.
Thank you, Dr. Ali, for a very informative presentation. It is now time for our question and answer portion of the program. If you would like a question answered, please feel free to click the Q&A button on the lower left-hand corner of your screen, type your question in the open area, and click Ask to submit the question. So our first question we have, is there any evidence that H. pylori infections may reduce the risk of some cancers? If so, how might H. pylori infection decrease the risk of some cancers but increase the risk of other cancers?
That's a very good question, also a complex one. I think, the pathogenesis of gastric cancer, H. pylori has been implicated in. So the question that has come up, especially in areas of high prevalence of H. pylori, which is much of the developing world, is that can screening for H. pylori and treating it reduce the rates of gastric cancer? And there have been a couple of studies done in Asia, in China, looking at this question. And essentially, what they have found was that there is sort of a histologic point of no return, that once patients get to the point of chronic atrophic gastritis, eradication at that point does not really affect their gastric cancer risk. But eradication sooner than when they develop chronic atrophic gastritis can reduce the risk of gastric cancer. So the subpopulation of patients who have not yet developed chronic atrophic gastritis seem to benefit from eradication of H. pylori in terms of preventing their gastric cancer. The second part of your question, I think, pertains to the fact that what we have seen in different societies is that gastric cancer is common. It's more prevalent in developing countries. And as societies sort of go through the trajectory of development, as they become more and more developed, sanitation improves, rates of gastric cancer decrease, and it's because the rates of H. pylori decrease in those societies. But what we see in these societies is an increase in the risks of acid reflux and esophageal cancer. Now, H. pylori is not causing this increase in esophageal cancer. I think it's more that the disease states are shifting. H. pylori is becoming less common in these populations, but at the same time, with the trajectory of development, body mass indexes or indices increase, people or the rates of obesity increase, and acid reflux, as we know, is associated with obesity. And with increased acid reflux, we see higher rates of esophageal cancer. So, in summary, eradication of H. pylori at an early stage can prevent gastric cancer. It does not increase the risk of other cancers. The increase in esophageal cancer that is seen in industrialized countries is usually the result of increased rates of acid reflux, which probably owe more to increase in BMI than anything else. Other questions?
Yes, we have another question. How is the organism grown for sensitivities? Will it work on automated systems? Will it grow on regular media?
H. pylori is a very finicky organism. It's very difficult to grow it in culture. And that's the reason why when patients have resistant organisms, it's very difficult to get sensitivity testing. You have to take biopsy specimens, and essentially they are grown in special culture medium, and even in spite of specialized culture mediums, there's a high rate of failure to culture these organisms. So we don't have a very good way to do this in an automated fashion. The susceptibility testing that I had discussed is a PCR-based testing. So that's not done by growing the organism. It's essentially, it can be done on a stool specimen where the genetic material of the bacteria can be extracted, and PCR testing for a mutation that predicts sensitivity or resistance to clarithromycin can be analyzed. So that is the more feasible, preferred, and practical way of sensitivity testing. Culture is cost and labor intensive and has a very high failure rate. Other questions?
Okay, we have another question. Does this mean that patients tested for H. pylori should have sensitivities run in conjunction with initial testing for H. pylori? How do payers feel about paying for sensitivities?
Well, the answer to your question is that it should. Ideally, it should. In fact, David Graham, one of the authorities on H. pylori, had said in an editorial that it may be unethical to do studies comparing sensitivity testing, treatment given on the basis of sensitivity testing versus empiric treatment, because any sensitivity testing should increase the yield of the treatment, increase the response to the treatment. So it's pretty well recognized that if you have guided treatment, if you have more information regarding which antibiotics the strain is sensitive to, the likelihood that your treatment will be successful is higher. So that's pretty well established. And on that basis, if susceptibility testing is available, it should be performed because it really reduces the patient's exposure to antibiotics that they are unlikely to respond to. So it allows us to target and to prescribe the antibiotic that has the highest likelihood of response. So the short answer is that it should be done in conjunction with H. pylori testing. Now, when it comes to payers, unfortunately, I can't, I can't answer for them. It depends on how the test is offered and, the cost and all of those things, and all that is not established. So ideally, there is a need for sensitivity testing if available from the standpoint of the patient, from the standpoint of good medicine. It has significant utility. How the payers respond to it, I honestly don't know.
Okay, thank you, Dr. Ali. We have one more question. We have time for one more. Can a patient be asymptomatic or a carrier?
Yeah, absolutely. Most people, if you think about the proportion of people who are infected, in the United States, 30%, overseas in many Asian countries, South American countries, African countries, the prevalence rates are as high as 60, 70%. So given that very high prevalence, most of those patients are not having symptoms. So the majority of patients who have H. pylori are actually asymptomatic. So it is certainly possible, and it is a fact that the majority of people who have H. pylori don't have symptoms. It's only the ones who have symptoms who come to our attention, but there's a very large proportion of patients who have the infection but have not yet developed symptoms, and there are many who may never develop symptoms, because a lot of people have H. pylori, but they always stay in the chronic superficial gastritis state for the rest of their lives.
Okay, thank you, Dr. Ali, and thank you for everyone for submitting your questions. If you did submit a question and did not get it answered, we will contact you regarding your question. So thank you to all of our participants for joining us today. We hope you found this webcast presentation to be informative. This concludes our webcast. You may now disconnect and have a wonderful day.